thank you so much for being here. What do you want me to do? Hi, this is Shawna Butler.
Hi, this is Rosa Hart. And we're recording? Okay. Hello and welcome to the Nurse Rosa's Insights podcast. I'm here live from the health conference in Las Vegas in the Venetian with my honored guest, Shawna Butler.
That is so kind of you to say that. And you know what? It is a real treat to actually be live. And so I really want to put a shout out. Thank you so much to HLTH for putting a lot of thought into their media village, making these studios available. We've got expert
recording studio people,
but also we have talent here because a lot of this, it doesn't go, they make us sound good. So I'm very appreciative of the people who are also on the other side behind the microphone. Makes a big deal.
Thank you.
Yeah.
And thanks to Dan Kendall, he's the owner of the Health Podcast Network, who arranged this time slot for us and special booths here. So we're so excited to be here because both of our shows are on the Health Podcast Network. And that's how we met on your podcast, See You Now, for the ANA and Johnson & Johnson. But now we're going to talk about who is Shawna Butler. And I can't wait to hear your answer to the billion-dollar question that I ask all the guests on Nurse Rosa's Insights. So Shawna, you're a nurse, right?
I'm a nurse economist. Yeah.
So is that like Nurse Plus?
Yes, it is definitely Nurse Plus. And there aren't very many of us. And what I start with is I always lead with nursing. And the reason I do that is because I'm very focused on clinical experiences and clinical outcomes for people, for communities, for the planet. And so a lot of people think that they understand the clinical value of nursing. We are scratching the surface on that. But there's a little bit more known about the clinical value. When it comes to the economic value of nursing, not the economic value of health or healthcare, the economic value of nursing. There is very, very, very little known about that. And we do have some economists out there who are health economists, they're labor economists. But I think one of the things that really differentiates me is that I am more translational. So I understand the economic literature. I understand a lot of what we're talking about in economics, but I really want to view that and translate it through what does this mean for nursing, for the nursing workforce, for the nursing profession, for our healthcare systems. And so I spend a lot of time helping people to understand that there is enormous value clinically, but also economically, particularly when you're thinking at a state level, at a city level, national, even international. We need to understand the economic value of nursing in terms of how we impact reducing costs, reducing disease burden, increasing wellness and health, lifespan, health span, our productivity. And that really comes down to, when you start thinking about moving further and further upstream and making sure that people have more days where they're healthy and productive, that's where nursing absolutely shines. We need all of our partners, but that is where nursing absolutely shines. And so oftentimes when we're looking at it through the lens of health economics or labor economics, we miss that clinical translation, that practice translation. And that's what I spend a lot of time doing, either working with tech companies or health systems or governments. I think the public is they've heard a lot about this nursing shortage or nursing crisis or healthcare crisis. And it really comes back to our workforces. And so that's what I've spent a lot more time in the last couple of years is talking about nursing care, nursing hours, as opposed to thinking it in a very narrow way around nursing shortage. There's a lot.
There's a lot of nurses who just don't want to work under certain conditions. And is that something that can be financially fixed? Well, let's go back first, though. Did you become a nurse first or did you become an economist first?
Nurse first.
Okay. And how long were you a nurse before you decided I need to become an economist to make more of an impact?
It wasn't very long. I started my career back when Florence Nightingale was making rounds, when, dinosaurs were walking
the original hand washers.
Yeah. No, it feels like that sometimes. I did. I started, I'm getting on to 35 years now, of having been a nurse, but I'm really grateful for the time at which I started my nursing career. We were at the precipice of another global pandemic at that point in time. We did not realize it was HIV. We had different names for it. Okay. So I came into being a practicing clinical nurse at a point in time when we were changing as a society, we were changing technology, we were changing, people throw around patient-centered care. That was not really the way we thought about things. So that there was a lot of shift in the way we delivered care, how we thought about it, who was at the center of it, how we paid for it. That was another really big piece. It was also a point in time when we didn't say the word, we didn't talk about sexuality. We didn't, it was very hard for people to say the word. Yeah, we had a very hard time saying cancer. It was known as the big C.
Oh my.
I know, it's been that long. So I came into my career at a time when a lot of change was happening socially, financially, technologically, practice-wise. And I'm really grateful for that because, when I take a look at people who are entering the healthcare workforce now in healthcare practice, healthcare was not an industry when I first started. We didn't have, we didn't have private pay hospitals in the same way that we do now. It wasn't the sector. I mean, when you think about hospitals, the names that St. Jude, St. Barnabas, Jewish Long Island, they all have some type of a religious affiliation.
Right.
And the vast majority of our healthcare was more in the charitable areas. It was nonprofit. We didn't think about the healthcare sector in terms of financial terms. So it was, like I said, I'm very glad that I started when I did, but I started out as a clinician, as a nurse who was working in critical care, oncology, MICUs, ICUs. And I also had this one really interesting role that is what planted a lot of seeds. I did international medical repatriations. So I got to go all around the world and I was transporting people from one part of the world to another. So from one medical setting into another medical setting. And there were no cases that were similar. But the similarities were somebody was not where they were not at home. They had an illness or an injury that caused them to be hospitalized. And they needed to get back. Probably it's usually home or to a better place.
Were you bringing them into the United States from other countries? Or
it was all over. Sometimes, I'll just think of off the top of my head. I picked up a young woman who was in Tel Aviv in Israel and needed to be repatriated to Toronto. And I picked up another elderly gentleman who was in Scotland that needed to be in France. So they were all over. So what the similarity was, they were in one part of the world, sick and ill and injured, and they needed to be in another part to receive either the better care or they needed to be repatriated home to receive the rest of their
flights?
Care. All flights.
You're like an international flight nurse.
Yeah, like that. But they were very specifically medical repatriation. So hopefully by the time we put them on a plane, they were stable. We tried not to have anybody that was unstable. That's, when we think about,
you had to keep them stable throughout the flight.
Right. When we think about medevac, that's usually you're in a really bad place. We got to pick you up. I mean, it's not that.
But if they're requiring that medical care and they would require hospitalization or something, then you would need to be present with them to make sure you're monitoring their vital signs and giving them anything to keep them stable.
We transported people on ventilators, transported people. Yeah. So
that is incredible.
All sorts of medical needs, but they were stable. So my point about that, which was quite interesting in the early part of my career, is that I got to see care delivered in all sorts of different places and different settings. And so when we talk about global health, oftentimes when people refer to global health, they're talking about disease burden and they're thinking about it from a macro level. What's longevity look like? How many people, what's the maternal mortality rate look like? What's the incidence of diabetes? So we think about it on a macro level. My exposure to global health was at the service line. What does pregnancy or diabetes or a car crash, any of those types of things, what does that look like in Scotland or Peru versus Pennsylvania? And so diabetes, childbirth, metabolically, physiologically, it's all the same. But the way, but when you're in these different places, context, infrastructure, training, values,
how you're supporting that person who's going through that metabolic
very different.
issue.
So diabetes is very different throughout the world, and not because it's different metabolically,
but because it's supported differently with different levels of support.
Different levels of support, different levels of medications.
And different medications are available.
100%.
Yeah.
So that was really the early stages of me being aware of, wow, diabetes is very, very different. Childbirth is very different. How we treat, what surgeries are available, how we treat cardiac disease. it's not just driven by science and evidence and breakthroughs. It's driven by what is available, what's culturally acceptable, what a country decides to invest in. And that was really when I started looking at this from that systems optimization as well as the economic piece. I also had one other pivotal experience early on in my career in that one of the patients that I took care of for a pretty long time, her husband was Fed Chairman Paul Volcker. So I got to know him in a way that, you know, when you're taking care of somebody long term and you get to know the family. Yeah. And it was former Federal Reserve Chairman who said to me, you know, all of my family has been part of the medical world. I've had a family member who's had long-term health issues. And what I find is you got a lot of folks who understand economics. And then you have a whole other group of people who understand healthcare.
And they do not mix.
But we don't have a lot of people who can think out of the same brain, who can balance and weigh what's the economic value and what's the clinical value and find a really nice marriage of those. So it was at his encouragement. He was the one, he said,
okay,
I see that you want to you want to have an impact at scale. You want to affect things. You want to do things that are going to affect more people. And he was the one that really convinced me he said, you know, I think you really should go study the economics of death, disease, illness, health, disability, because we just don't have a lot of clinicians who have that type of background. Now, I was it was a pioneer, I would say, in a lot of that. Now, when I look around, I'm really excited to see that there are more clinicians who are taking this additional lens to say, here are all the things that we can clinically do. We've got science, we've got the technology. We can actually do this for people. We can help improve our health outcomes and our health experiences through that. But how are we going to have a financial model that's sustainable? How are we going to pay for this? How are we going to do it in a way that's equitable? How are we going to do it in a way that's accessible? So it's this really nice, I think, you know, where we are right now with this, and we're seeing a lot of the discussions at every health conference, and this conference specifically, you see the discussion more robustly about the use of generative AI in general, but all of those technologies that are in that sandbox. How do we use this technology to reach more people, to reach them earlier, to be really great tools for our healthcare workforce? What is the business model, the economic model to make all of this work? I know that you've got a big question for me because I've been thinking about this.
You inspired my big question, by the way. So let me take a moment and just explain to everybody that Nurse Rosa's Insights podcast came to be, one, because the stroke podcast I was doing got a lot of attention and people all over the world started reaching out to me saying, hey, I have a great idea I want to talk to you about on your podcast. And I was like, that's great, but it has nothing to do with stroke. So let's make a new podcast. But then as I thought about that, I was like, well, what would the format be, right? Because it would be a very different format. And I was listening to your podcast that you do for the ANA in partnership with Johnson & Johnson called See You Now, which is a big deal, by the way. Thank you so much for having me on the other day. But I was listening to you talking about this series on philanthropy in healthcare, particularly as it involves nursing. And you shared about how this survey that was done by the American Nurses Foundation.
Obviously, I can just give a little bit more color on that.
Please.
So the name of that series, and it's a 3-part series, it's called Investing in Nurses. And it was very intentional because investing, first of all, that's a verb and it's being done.
Yes.
And who are we investing in? It's investing in nurses. What that was inspired by was the American Nurses Foundation started looking at philanthropy towards nurses. So there's wild agreement across every group that looks at how do we make sure more people have more access to healthcare. So whether that's the World Health Organization, whether it's the World Economic Forum, whether it's McKinsey doing their workforce studies, it's any of the Health and Human Services, Department of Labor, everybody has said, if we are going to have better health outcomes, people need to have access to care. When we're thinking about universal access, universal coverage, the key to this is nurses and nursing. Wild agreement. So if everybody's in wild agreement, how much money is actually being invested in nurses? So the American Nurses Foundation said, that's a good question. Now, this is only philanthropic dollars.
Yes.
So let's be really clear that to invest in anything, investing, but particularly in nurses, and 4 things that we need in our society. That's government investment, that's industry investment, that's professional investment.
But through a charity lens in this case.
No. Let me just finish up here.
Oh, sorry.
When we talk about different types of investments, you could have government investment, you could have all these different lanes of investment. What the American Nurses Foundation was looking at is only those dollars that are in philanthropy. Okay, so there's still a bunch of other money out there, but probably this study, which is the only one that's actually looked at, how much money is actually invested in nurses. While there's this wild agreement, we all want better health, and this is the way to do it. So they looked at all these philanthropic dollars, billions of dollars going into healthcare, philanthropy dollars going into healthcare. And of those billions of dollars, only 1 penny out of every dollar actually goes to nurses and nursing. And then we drill down even further. Yeah, 1 penny. So when we drill down further, why this is really important to understand is that when people think we need to invest in nurses, the knee-jerk response, the most common response, and where we see 75% of that philanthropic investing is in scholarships, making sure that we can get nurses prepared and into the profession. Less than 25% is going to leadership or our current nursing workforce. And what everybody's reading in the headlines, and this is global headlines. Everywhere you go in the world, you will see something that says nursing shortage. What they're really referring to are nursing vacancies. These are, we need this amount of nursing care. We need this number of nurses to be able to fill it. We've got open jobs here, and nurses aren't coming to fill them. And this is not because there aren't enough nurses out there right now.
Right.
It's because what's being offered to them, many nurses, I don't want to work in this setting. I don't feel safe in this setting. I don't feel supported. Where's my career advancement opportunity?
Right.
So some of the insights out of that study, number one is, if there's wild agreement that our way to better health is through nursing, we need to be putting a lot more money in. And just think about that. If it's only 1 penny out of every dollar, what if we change that to 10 cents? Like it would be wildly impactful.
Yeah.
But the other part is, like, where are we making those smart investments?
It has to be done strategically.
It has to be done strategically, because right now, when we train nurses, if they're not choosing to continue in that career, then we're on this continual
hamster wheel
where we train nurses, they come into the workplace and they're like, this doesn't feel safe. I'm not here able to meet my mission. So those dollars, those 75% of those investment, those philanthropic dollars, they're not going to have a duration. They're not going to have a longevity. We won't have somebody in that profession.
It's not sustainable.
So another really key insight out of that is, not only do we need more, but where do we put that money? And if we put that money in our current workforce, we cannot afford to lose any single nursing expertise, not a single drop of it. Because that nursing expertise, that's where we get our educators, that's where we get our leaders, that's where we get those who are going to mentor. So if we focus on that part of the nursing workforce, and we put those exact same amount of dollars in, even if it didn't increase, which there's no excuse not to be increasing it, we would see those dollars have greater impact. So again, this is, that why do we need people in economics and nurses who understand economics? Because we have to be really smart and strategic about where that money goes.
Yeah.
And so, every health system right now.
Exactly.
And in my goal at this moment in time, I have a lot of nurses say, "Oh, I want to go down your route." And I said, "Well, that's interesting." And I would love to support you on that.
That's interesting.
And what I'm really hopeful for is that we see nurses combine their clinical education and go to the adjacent fields and become the chief technology officers, become the chief financial officers, to be more involved in how do you make the business case for the clinical care or the program or the policy.
Exactly. Or marketing, right?
All, the way
how do we improve public health messaging through marketing strategies? Because if you want to get a message out there, who knows how to get messages out there? Marketing. Let's do it.
They do. And we need really good storytellers. There's no shortage of great stories, but how we reach people, I think that's one of the real challenges that we have across the world right now. And this has been identified by the World Health Organization. One of the greatest threats that we have to global health is misinformation and disinformation.
Exactly.
So when you think about what's the fix for that, It's people who have really good information being in all the places where people want to get their information and how they want to access their information. So if we have experts, nursing experts who are experts in stroke, in mental health, in diabetes, in childhood illnesses, in healthy pregnancies, 100%. If when you're pregnant and you're worried and it comes up at 2:00 in the morning and you can't go to sleep, you're not calling your nurse midwife. You're not calling your provider at that hour. You're scrolling through the internet.
Yeah.
So, but what that means is those midwives, those doulas, those obstetricians, they can be there with information that is good information, that is well communicated, that is available and on demand. So I put that out there. I mean, you and I both have a real trust and belief, and we've seen the proof in the listenership and the people getting back to us.
Yeah.
Podcasts and being media savvy is a really good way to reach people with evidence-based, understandable information that has context for their lives, their community, their current situation. And the way, I say that really specifically because the way we would talk to a 12-year-old about diabetes is not the same way we would talk to a 32-year-old or a 52-year-old.
Yeah.
So that's why we need lots of people out there communicating in lots of different ways, because there are lots of different audiences. While they may have the same diagnosis, they're not in the same stage of lives. They're not in the same environment with the same types of resources.
Yeah.
So I encourage more people to take your information out to where people are seeking to get it.
Definitely. And so I'm going to ask you the $1 billion question that you inspired, which is, Shawna Butler, if you were given a grant for $1 billion to fix the needs that you see in healthcare, how would you like to see that used strategically to have the most sustainable impact?
It doesn't take a whole lot of money. That's the surprising thing. We spend more money and time avoiding doing what we know will work, fighting against what we know will work. The thing that needs to happen, because the thing that needs to happen is we need to align our financial incentives with our health outcome and health experience incentives. And as long as they are perversely aligned or misaligned, however, sometimes it is perverse, sometimes it's just a misalignment. But if our financial incentives are not, if we don't start with, let's put it this way, we need to start with what are the health outcomes and the health experiences that we want to have? How do we want people to live their lives? We start with that. And then how do we financially incentivize that type of behavior, that type of system? And until we do that, and we haven't done that, particularly in the U.S., I mean, when you start looking at our peer nations, and let me just be really clear, no country on the planet has got it all right.
Right.
Not a single one.
But are there examples of those that you would think we could mimic?
Well, that's the challenge, because every country has their own identity
and their own
culture and their own way of doing things. So it's very hard to say, let's take the primary care that they have in Israel and let's bring it to the U.S. Love what Israel does with primary care. Love what primary care looks like in Cuba, what it looks like in Costa Rica.
Really?
Amazing impact that they have. Amazing. But oftentimes, so it's a good model, but oftentimes it doesn't work in that culture. We're just going to have a hard time accepting that. But what we can look at is what is actually working and how do we fit that in to what we're doing. What the U.S. is particularly good at and the rest of the world benefits, research and development. The fact that we have these incredibly effective and safe medications in the world, that is because the U.S. is so good at research and development. Why does every country want to come here and bring their product, their technology? Because we got a huge market that's very good at being able to disseminate that. Wouldn't that be great if it was equitably disseminated across the U.S.? We haven't done a good job with that. The Commonwealth Fund, every year they look at the 11 economic leaders and look at how their healthcare systems are performing. And on pretty much every metric, the U.S. is falling far behind. We spend way more money than our peer nations, and we have worse health outcome. We're living shorter and sicker lives than all of these other countries. And when you start looking at it, we haven't invested in public health and primary care the way Sweden, the Netherlands, UK have. So lots of examples out there, but we have to find the way that we're going to do it that matches our identity and our national identity. But the biggest thing that if I, like I said, that you give me $1 billion, I want to be in that place of how do we align, how do we get the right financial incentives? And the way we do that is we start out with what do we want our healthcare outcomes and healthcare experiences to look like? And then we start matching those financial incentives to it. And it's until we do that, it's going to continue to be as hard as it is. There's a lot of distortion. That sounds really, I'm not unhopeful, but it's just a lot of hard work. And so when you have people who have been benefiting from the way I don't want to call it system, but I will use that word for lack of a better word. But because that is the way our system works right now, we're going to have a very hard time getting to a better place until we get to a place of let's look at how do we align health outcomes and financial incentives. And when we do that, there's no shortage of technology. There's no shortage of expert, caring, smart healthcare teams to deliver the care. But until we get to that place of we're aligned on the financial incentives, it's going to be really hard. So that's where, the economist in me is like, let's start looking at let's take the health outcomes and experiences that we want, and let's find financial models that match that better. And like I said, I say that, and I know at the same time, it's a lot of hard work.
Yeah.
It's a lot of opinions that we have to change. I thank you so much for the limited time that you have here, that you would spend it with me. That means a whole lot.
Well, your time is valuable, and I really
$1 billion minutes here.
Exactly. Well, I really appreciate your investment of time into making the world a better place. So thank you, Shawna. Your time on the clock, off the clock. You make time where there might not seem like time. So thank you so much for being here. And stay tuned for the next episode of the Nurse Rosa's Insights podcast. Subscribe on your favorite platform, and I'll see you in the next episode.